Hello and welcome to another lecture for my class, PSYC 770, Psychological Testing and Assessment. And I'm beginning today with a comic from the excellent webcomic series xkcd.com. It may not seem to have a lot, at least immediately, to do with psychological testing, but maybe you'll see a connection a little bit later on in this lecture. And the lecture is called Introduction to Validity, and it is more or less as titled, a little bit of a talk about the idea of validity and some of the different ways that we can estimate or at least describe validity. I think you'll see in this lecture that unlike reliability, for the most part it's difficult to come up with numerical estimates of validity. There are a couple areas of exception to that point, but I think it otherwise generally holds. So by way of an overview, I'll first offer a rather general definition of what validity is. I'll talk a little bit about content validity, what it means to try to represent a population or a universe of content on a test. Talk a little bit about criterion validity and how it relates to decision theory, although in my next lecture I'm going to spend quite a lot more time talking about decision making and how we can use decision making to evaluate the criterion validity of a test. So I'm kind of pushing a bit on that one topic. And then I'll finish up by talking about construct validity. Construct validity is a kind of a unifying way of thinking about validity, and it's a concept or an idea that you've probably encountered in other classes, but it has some real origins and some current applications in the world of testing. So here's my very general definition, or rather I suppose first a very general question. The question is, when is a test valid? And the answer that you probably can think of immediately or that you might remember from another class is something like when it measures what it claims to measure. So we have a notion that validity is in a way synonymous with accuracy or truthfulness. We say a test is valid when it's measuring the thing that it purports to measure. Now, as you know, various organizations put forward standards for testing, including organizations like the American Psychological Association. And if you look at these standards, it's interesting to note that in their discussion of validity of testing, the focus is not so much on the test as on the types of inferences or indeed the assessments that are made from the test. So we might say that a particular inference made from a test is valid if it is appropriate, if it is meaningful, even if it is useful. The key note that I'm trying to make here is that a test really isn't valid per se. The inferences or the conclusions that you draw from the results of that test may or may not be valid, depending a lot on the context in which the test is being used, the population in which it's being used, and the purpose for which it is being used. Now, when thinking about validity, it's interesting, of course, to make comparisons to reliability, and as you probably know, or certainly as you'll see a little bit later in this lecture, there are some connections between reliability and validity of tests. In many ways, though, talking about and thinking about validity is more complicated than talking about reliability because there are a lot of different ways to measure validity. I mean, truthfully, of course, there are different ways to measure or to estimate reliability. The ways of estimating or even just discussing validity are more numerous. There really is no one precise or best way of thinking about validity, and as you'll see a little bit in this lecture, there really are fewer numerical estimates that can be made about validity. So it's a little bit more complicated than talking about reliability, but in some ways it's similar. And a point that I made about reliability, and I'll make again here, is that we shouldn't necessarily think of a test as being valid or invalid, or maybe more precisely the conclusions drawn about the test being valid or invalid, but rather there being some sort of a continuum of validity for the types of inferences we make about a test, from very weak to acceptable to very strong. And again, as I've kind of said already, it's always important when thinking about reliability, when thinking about validity, to keep in mind the context, the application that the test is being put to. Okay, so with all that in mind, there are kind of three traditional notions of validity that we encounter in most testing and assessment textbooks or research methods textbooks. You've certainly seen these before in other classes. There are also all sorts of other kind of versions or flavors of validity that I'm not really going to touch on right now. I think I once joked in one of my other classes that if you ever wanted to write a paper and you were out of ideas, just coin a new type of validity or come up with a new phrasing or formulation for validity, and at least a few people will probably read that paper. Now, for our purposes in this class, in this lecture, we're going to think about content validity, criterion validity, or sometimes called criterion-related validity, and construct validity. And it's worth pointing out that good test validation, that is the process of of understanding the validity of testing, involves all three of these. So if you were developing a test yourself, you would hopefully explore the validity of the test or the validity of how the test is used from these different notions or different perspectives. You wouldn't just say, well, I'm comfortable with the content validity of this test and therefore I'm done. It's an ongoing process, as I mentioned on my previous slide, and it involves evaluating or considering these different features or facets or perspectives on validity. Now you may have noticed in that previous list I didn't mention face validity. Face validity you've probably heard of in other classes, but it's often kind of lumped in with discussions of these more traditional notions of validity. And face validity is sometimes disparaged as not really validity or not really a form of validity. It refers instead to the extent to which a test appears to measure what it claims to measure. And so some people might say disparagingly, well, however much a test appears to measure something isn't really all that important. And in any way, it's worth asking, appears to measure to whom? To the test takers themselves, to the test administrators or test users, or to the public in general. I would argue in this lecture that face validity is not unimportant. Fair enough, it's probably less important than these other forms of validity that I'm going to spend more time talking about and that your textbook spends more time talking about. But face validity is not unimportant. Because you could imagine tests with very low face validity. Indeed, there are some tests. There's some elements of the MMPI which have, I think, rather low face validity, and these can be frustrating to test takers or could be misunderstood by the public. You can, of course, easily come up with examples of tests with high face validity, tests of constructs which seem quite obviously to be measuring them, questionnaires about depression which ask, are you feeling depressed? These are tests with high face validity. And I guess potential risk there for those type of tests is that they can easily be faked, or maybe more easily be faked than tests with low face validity. The point here is that what a test looks like to the person using the test, to the person taking the test, to other people who are involved in the testing and assessment process may be important. And it may especially be if we want to avoid things like frustration or if we want to avoid things like faking. And so you could imagine if you are developing a test, you might spend some time thinking about face validity, even if that's not as much time as you spend thinking about other forms of validity. And if you're someone who's a test user, you're a clinician, you're picking a test to administer to a client or to a patient or whatever, you might be at least somewhat concerned about the face validity of the instrument. If you think there's a high risk for frustrating your client, you may want to avoid a test which seems rather opaque and has low face validity. If you're studying something or measuring something which you think might easily be faked, or where the client or the test participant might want to fake their results, you might choose to avoid a test with high face validity because you want to make it hard to fake. Anyway, you get the idea. Face validity, often disparaged or dismissed, but not unimportant, at least not as far as I'm concerned. Moving on, let's talk about content validity. Content validity refers to the extent to which a test captures the universe of behaviors that it claims to capture. And the idea here is that the test is really a sample of behaviors. And I've mentioned this in other lectures, I know, and I've certainly said this in class to those of you who are taking my class, that a test is a set of items, often they're questions on a questionnaire, that are a sample of a possible population of items that could be on that test. There are 10 items on your questionnaire, on your test. There may be hundreds or even thousands or tens of thousands of items that could have been on that test, and for whatever reason you chose those 10. It's a sample, and it's necessarily limited in that sense. It cannot be all the items that could possibly be on the test. It is hopefully, though, a representative or generalizable sample of that universe. So if you're making a test, or if you're choosing to use a test, you might well ask yourself, well, what is this universe of behaviors? What are all the things that go along with the construct that I'm interested in measuring? And often it's actually hard to answer that question. It's hard to know the full extent, I suppose you could say, of the universe of behaviors that accompany or characterize a particular phenomenon, a particular construct. It's maybe somewhat easier if we know a lot about the construct, like if we were working in an educational setting and we're trying to measure some level of achievement, like math achievement or reading achievement. Maybe it's relatively easier to come up with a list of items that are characteristic or are included in that universe, knowing how to do certain operations in mathematics, knowing how to solve certain problems in mathematics, and so on and so on. Maybe for a construct like depression, which in clinical psychology is fairly well understood and has been studied for quite a while, we might be able to come up with a pretty good list of features, symptoms, signs, etc. of depression. Although in both of those examples, achievement and psychopathology of depression, you could still disagree with other professionals or be uncertain if you got it all when trying to describe that universe. In other areas of study or other areas of clinical testing and assessment, maybe this is even harder. People who study creativity, or people who claim to be able to measure creativity in clinical settings, probably have a tough argument to make that what they are measuring is representative of the full universe of behaviors that is creativity. Or obviously there's a lot of interest these days in clinical psychology in mindfulness as a construct, as an element in the therapeutic process, perhaps trying to describe exactly what is, or what are all the elements or behaviors that populate the universe for mindfulness, I think is quite hard. I mean, arguably people have for thousands of years been sort of philosophizing and debating on that one. So anyway, you get the idea, I hope. It's when asking about content validity, we're trying to imagine what is the full universe or full spectrum of behaviors that characterize a construct, and often in asking that question we can't come up with a really good answer. I guess if you haven't already started to do this, here's an opportunity for you to practice. Pick a construct you're familiar with, something you study in your laboratory, or perhaps something you have observed in a clinical setting, and just take a minute and try to come up with as many facets or features or signs or symptoms or behaviors that go along with that thing, with that construct, whether it's depression, alexithymia, mindfulness, neuroticism, and so on and so on and so on. The important point, or the sort of the consequence of that little exercise is hopefully you'll realize it's pretty hard to come up with content. Constructs in psychology are abstractions. Depression, alexithymia, mindfulness, they're hard to observe in a full and concrete way. And for what it's worth, this is the tie-in to that little webcomic at the beginning. We often in psychology and in the behavioral sciences, let's say, we feel a bit bad. We say, oh, we study these abstract constructs. I wish we were in the hard sciences where it's so much easier. Well, talk to a physicist and he or she will explain that there are things in their so-called hard science which are quite difficult to describe, whether it's quantum field theory or particle physics or so on. So we're not alone in that. We're not alone in trying to really, or struggling perhaps, to describe the content of a particular phenomenon or construct that we're observing. A related idea that goes along with this is considering the types of measurements that we use for these behaviors. Like, let's say we've come up with a list of behaviors or signs or symptoms or features or whatever that characterize depression. We can also ask, what are all the different ways of asking questions or making measurements about all those items? What's the format that we could use for different ways of testing all those things that we just sketched out on a piece of paper or on a whiteboard? Often, of course, in tests, we use multiple choice items. I mean, I'm, as an educator, guilty of overusing, I'm sure, multiple choice items on tests, homeworks, etc. I'll be honest, and hopefully most people would too, that this is more out of convenience than out of any particularly good reason. In psychology, we preference often linguistic assessments. You're asking people questions, asking them to rate on rating scales, Likert scales, multiple choices of various sorts. You could well ask, is this way of testing, or this particular way of testing, the best representation of all the possible ways that you could test? There's a universe of content out there that characterize or are associated with the construct, and there's a universe of assessment possibilities, and we could imagine trying to, ideally, I suppose, represent that universe of methods as well. So another quick opportunity to practice: think about that content that you came up with on the previous slide and try to come up with some different ways, or as many different ways as you can, of measuring it. So let's say you were trying to characterize the construct depression and you wrote things like sadness, anhedonia, sleep disruptions. What are all the ways you could measure each of those three things? Asking someone to self-report their sadness, asking a friend or partner to describe the person's sadness, observing them in a behavioral sort of observation type paradigm, and so on and so on. I think if you do this, you'll come to the important point that it's hard to come up with methods too. It's hard to come up with content when you're concerned with content validity. It's hard to come up with methods of measurement or testing when you're concerned about content validity. It has to do with the theoretical considerations that you've made. What is the theory you have of this construct? What do you think is important about it? Also, of course, it has to do with practical considerations. It might be ideal, I suppose, to surreptitiously observe people for long amounts of time and measure their levels of expressive sadness or their apparent disruptions in sleep. Indeed, with modern smart, wearable technology and smartphones, maybe people try to do this, or not maybe, they certainly do try and do this. The data analytic considerations of that type of work are themselves quite significant. The point is, it ain't easy, and it challenges us, and that can be daunting, or I suppose that can be inspiring, depending on your personality and perspective. Anyway, when we think about content validity and we try to come up with a way of putting a number to it, quantifying it, what we're often left doing is coming up with some sort of set of expert raters who would look at a potential set of items on a potential questionnaire, something we're developing, and give their opinions. Now, who these experts are, of course, is going to vary depending on the type of test we're developing, the type of applications we hope to put it to, and so on and so on. And researchers, clinicians, perhaps clients should be asked, educators, administrators, and so on. You could imagine a very simple situation in which we had just two judges who were looking at a set of items, and each judge is going to rate an item based on whether it has weak or strong relevance to the construct or the phenomenon of interest, and we could thus have kind of a four-square, and we could choose, of course, only the items that are rated strongly relevant by both judges, or we could even try to compute kind of a simple fraction of saying the items which are rated strongly by both judges divided by the total number of items give us a kind of a rough numerical sense of the content validity of our test. And if it's quite high, then most of the items were rated strongly relevant by both judges. If that quotient is rather low, then many of the items, or indeed most of the items on our test, were rated as weakly relevant by both or at least one of our supposedly expert judges. Now, if we have more than 2 judges, things get a little bit more complicated. We could, for instance, take an average of all pairwise comparisons across all the possible combinations of judges, or, as I rather briefly and probably in a rather incomplete way in my last lecture explained, there is a whole group of statistical calculations called intraclass correlation coefficients, which can be done to describe or to numerically express the extent to which a group of people are going to give consistent ratings of anything, in this case maybe items on the test. And so you could imagine situations, and I, for what it's worth, have done a little bit of this in the distant past, to express the level of agreement among a group of judges for a set of items. At the risk of digressing too much, I'll just say that way back when I was in grad school, I worked in a research group that was trying to develop a list of competencies that early childhood educators and professionals should ideally have if they were going to open a daycare or an aftercare program or so on. So we had a list of a very long list of items. I mean, upwards of 100 little proficiencies or competencies which people at this institution where I worked thought were important, and it was my job to try and come up with a way of getting a sense of the content validity of this group of items. And so what I suggested we do is we send out these items to a number of professionals in the field, people who were developmental psychologists or clinicians or administrators of large child care systems and so on and so on. We got back each professional's rating of each item, so we had a very large matrix of data, and then I computed a bunch of interclass correlation coefficients to kind of express the overall content validity of the set of items. To what extent do most of the raters think that most of these items are mostly relevant or important, and then also to suggest areas that we could cut out, so items that we could drop because not everyone thought they were important, or maybe even very few people thought they were important. It was an interesting and somewhat challenging process for me at the time, but I think it did teach me a little bit about this set of statistical operations, but also more generally about that idea of exploring the content validity of a test. And our goal was to come up with a checklist that was relatively small, didn't contain hundreds of items, and that we could use that checklist as a way of assessing whether a particular child care setting had the stuff that the experts thought it was supposed to have in order to provide the adequate types of care and developmental considerations that any parent or professional would want for children. End of digression, and moving on. Maybe the important point I'd like to make here, or at least one important point I'd like to make here, is when we think about content validity, it's fairly easy to think about the items you have, like to look at the items on your questionnaire that you're developing, or the items on the questionnaire that you've pulled off the shelf if you're a clinician, and say, how well does this represent the content in the universe? I mean, it's not totally easy, but let's say it's fairly easy. It's somewhat harder to think about all the items that aren't on the questionnaire, and people who do test development often struggle to not miss out on something important, to develop a questionnaire that somehow misses some key element which really should be on it, and thus it's helpful to talk to other professionals. And another important point I'd make is that it's relatively difficult to quantify content validity. That's a true point about most forms of validity. It's hard to come up with a neat, sort of clean numerical estimate. There are some ways, one of which I showed you, a couple of others I just vaguely mentioned. It's worth noting that in almost all cases, estimates of content validity have to do with expert opinions, judges, people who ought to know about child development or ought to know about depression. This is a good thing, I suppose, and it probably should highlight for us the value of training and experience. if you're in a clinical psychology program, you spend all this time learning about various areas of study, your main area of research, testing and assessment, like in this class. You get practical training on practica or on internship sites and so on. What's all this for? What's it good for? Well, hopefully it gives you the knowledge and the insight to, if you want to develop an instrument, a test, to not miss out on something important. Or if you're asked to consult with someone who's developing a new test, someone says, hey, I know you have research experience or clinical experience in eating disorders. I really want to develop a new scale to measure binge eating or something like that. You have some expertise, and that expertise can be useful when it's harnessed or connected to the psychometric process. Meal and other authors have pointed out that this is something that clinicians can do. This is something that's really important in what they do. Moving on, let's talk a little bit about criterion validity, or sometimes called criterion-related validity. This is the extent to which a test agrees with a criterion. And this criterion could be, well, it could be almost anything. It depends a lot on the application and the context and the setting and so on. It could be some sort of an outcome measure. So you could imagine you're developing a test of academic achievement, and well, hopefully that test is going to be in some way related to actual academic achievement. It will be related to grades or passing classes or achieving honors. Maybe your criterion is expert judgment, like you're developing a test which will be used for diagnosing a particular illness or disease. Hopefully your test results will have some sort of relationship to the decisions made by trained diagnostic professionals, doctors, psychologists, other healthcare providers. Maybe you're just trying to develop a new version of a test, and you want to see how well does your test compare to some well-established and maybe better test. Perhaps in your field of study there's a gold standard, a test that everyone thinks is more or less the right way to measure a particular construct, and your hope is to develop some new test that has a good and consistent and positive relationship to that pre-existing gold standard or better test. And if we want to get really fussy about it, we could say that there are two kinds of criterion validity. I don't know if this is really a super important distinction to make, but it's kind of interesting. You might note that you could administer your test and you could in some way measure the criterion at the same time. So you could imagine you're administering some test while at the same time having a diagnostician make a diagnosis. And if you're doing that, the form of criterion validity that you're investigating is concurrent validity, because these two measurements, your test and whatever the criterion measurement is, they're occurring at more or less the same time. That would be somewhat distinct from predictive validity, where your test occurs at one point in time and then sometime later the diagnostic is run, or maybe the ability is measured, or the outcome, the achievement is measured, and then we ask, how well did your test predict that outcome? For instance, tests like the SAT and the GRE are advertised by their developers as being predictive of success in undergraduate or graduate education. You could well ask, what's the predictive validity of these tests? And if you're asking that question, you're asking about their criterion validity. How well does the SAT, which you take probably in high school, predict how well you'll do in college? In your first year of college, your second year, your likelihood of graduating college, and so on. Sidebar, that predictive ability is actually really low. So you could perhaps argue, or certainly critics of the SATs argue, that their predictive validity, their criterion validity, is not that strong. Of course, a big concern in studying criterion validity of a test is the validity of the criterion itself. The whole idea of criterion validity assumes or hopes that the criterion is valid, is reliable. Whether it's the outcome that we're measuring, or the work of the diagnostician, or the better test, is that test really a gold standard? So we can ask, and it's important to ask, what are the characteristics of a good criterion? Well, kind of like I already said, one characteristic is that it's valid. Is the criterion accurate in itself? If not, why are we treating it like the criterion? And in clinical research, we often use the diagnosis made by a trained diagnostician as the criterion. So how well does your screening instrument for, let's say, depression match up with the diagnoses made by trained diagnosticians who actually sit down with the clients and ask questions and consult their DSMs and so on. Now, that makes sense, of course, but I think anyone who's done clinical work knows that diagnosticians are not perfect. They make mistakes as well. So we hope that our criterion is valid. But it's worth saying, or it's worth asking, how do we know how accurate our criterion is? Well, we could imagine we validate our criterion against some other criterion. So we say, how well does our test compare to the work of the diagnosticians, and how do they compare to some other test, and how does that test compare to some other test, and so on and so on. It's often, I guess to be clear, the point I'm trying to make is it's often the case that we can't be entirely comfortable in how valid our criterion is. At the very least, though, we should have a good rationale for using this criterion or treating this other thing, whether it's a diagnostician or some other test or some outcome measure. We should have some good reason for choosing that as our criterion. If not, I think the whole enterprise or the whole idea of evaluating criterion validity for this particular test is questionable. So a good criterion should be valid. A good criterion should be reliable as well. And this is an interesting point to dwell upon for a second. An unreliable criterion is going to be inherently unpredictable. So if we're asking how well does our test, let's say, predict some subsequent test, what is the predictive validity, the predictive criterion validity of our test for some other gold standard that's administered later in time? Well, if that gold standard test is unreliable, it tends to be highly variable in terms of the results it gives, then that creates kind of an upper limit on the validity that we can compute for our test in terms of predicting it. And you can actually mathematically express this. The formula here is obviously not too complicated, but you could create an upper limit validity coefficient that's just the square root of the product of the test's reliability, that is your test that you're developing, and the criterion's reliability. And you can imagine the less reliable either of those two things are, the less valid the test can be, at least from a criterion validity perspective. So reliability is linked to validity, and it's linked in this kind of interesting way that it creates kind of a ceiling on how valid a test can be. And that hopefully makes some sense to you. I mean, maybe that's something that has a certain sort of intuitive obviousness to it. If you have a test that's highly unreliable, it has no hope of ever being valid. It's you could say, or it's often said, I suppose, in research methods classes, that reliability is a necessary but not sufficient criterion for validity. Or to put that more simply, let's just acknowledge that reliability and validity are linked. And in this case being criterion validity, the reliability of the criterion influences the estimate of the validity that we can make when using it. Hopefully that kind of makes sense. And again, I think it's kind of an important point. So to quickly step back and review, a good criterion should be valid. Of course, a good criterion should be reliable. Let's hope, because otherwise it's going to really limit its usefulness. A good criterion should be uncontaminated, and uncontaminated in this context has a rather specific meaning, and that is that the criterion shouldn't contain the same items as the test itself. So if your test and your criterion, let's say your gold standard test, use essentially the same items, or even worse, exactly the same items, then it's not very interesting to say we are measuring, or it's not very truthful to say that we're measuring criterion validity. I mean, in an extreme of this, you might imagine that the criterion, the gold standard test, just has very similarly worded items to our original test that we're trying to validate. What we're doing then looks a lot more like alternate forms reliability analysis than it does criterion validity analysis. So, we want to make sure that our criterion doesn't have exactly the same content. I mean, clearly, our gold standard test or the work of our diagnostician can ask similar stuff, but we don't want to ask too many of exactly the same questions, exactly the same content, nor do we want to have it be exactly the same type of questions. It's not ideal if our test that we're trying to validate and our gold standard criterion test that we're using for this process ask the same questions in the same way. To be a bit fussy and technical, this is sometimes called a problem of method variance. And indeed, people who are critical of psychological testing, at least sometimes will point out that a lot of our tests involve asking questions the same way. We're often using self-report. We're especially often using self-report with 5-answer Likert scale items. The tendency, of course, is for things asked in the same way to be similar in terms of their responses. And the important point is that criterion contamination of this sort inflates validity estimates of the test. It makes, or at least potentially, makes our test look more valid than it really should. So to give a bit of an example of that, you could imagine having a test where you are measuring depression and you're trying to see how well does your test compare, how well can we evaluate its criterion validity against the Beck Depression Inventory, second edition. So let's call that a gold standard for measuring depression. Well, if our test asks more or less the same questions that are on the BDI, or it even asks them in more or less the same way, using like a Gutman scale response type, which is what the BDI uses, then the correlation between our test and the BDI might be overly high. It might be an overestimate of the criterion validity of our test. We should at least keep that in mind if we were trying to make a bold claim that our test had high criterion validity because it was just highly correlated with the BDI. We're often, of course, or I guess as you could hopefully see in that example, we're often looking at the relationship between our test and the criterion test, or whatever our gold standard is. If we're talking about concurrent validity, concurrent criterion validity, we can look just simply at the correlation. What's the correlation between my test and the criterion test, or the criterion measurement, whatever it happens to be. So again, if you're looking at diagnosis, for instance, we might administer a test and then at more or less the same time have the doctor or the psychiatrist or the psychologist make the diagnosis and see to what extent is there a correlation between those two measurements. If we are looking at predictive validity, we might well imagine administering our test at some point in time and then down the road measuring whatever the criterion is. So it might be something like we have an ability test, a test of someone's mathematical ability. Maybe our criterion will be their grades at the end of the semester in their math classes. Or in a clinical screening situation, we might say we're screening for suicide risk or risk of developing an eating disorder, and so we administer our test, and then at some point down the line we evaluate to what extent did people attempt suicide, or to what extent did people develop that eating disorder. Here we could use just simple correlations, but we might prefer to use a regression, and we might try to build a model where we predict the criterion based on data from our test. How well does our test predict what happens with that criterion measurement? Now you're of course familiar with regression from other classes, but just to kind of continue, we'll say that in this case we're predicting, or we're estimating the criterion score. We can actually express the standard error of that estimate using a formula like this. So we can compute, in a sense, the average of the errors in estimates that we're making with our test. Now, in past lectures, we talked about standard errors of various sorts, and just by way of a quick review, the standard error of the estimate is a way of describing the error in measurement which is related to the unreliability of the test, and we can use that to make confidence intervals around measurements. So, a confidence interval around a point estimate of someone's intelligence or someone's level of depression or so on. It's a similar idea with the standard error of the estimate. We're just talking about an error in prediction, which we could argue is caused by the invalidity of the test, the extent to which it doesn't measure the thing that it's supposed to measure. And likewise, we could put confidence intervals around the estimates or the predictions that we make using that test. So it's a similar idea. So often when we use tests, we're interested in measuring some sort of continuous outcome, or in the case of criterion validity, comparing to some sort of continuous criterion. So we might have a test that measures level of, let's say, suicidality, assuming that that's some sort of a continuous dimension, and we might compare that to some sort of other instrument which also measures suicidality, like the Beck suicide scale, either concurrently or predictively. Sometimes we are trying to use our test to connect to or to compare to some sort of a categorical criterion. So we might have a test that measures level of suicidality and then yields some sort of an outcome decision like high risk, low risk, and then we might want to compare that against some sort of categorical outcome or categorical continuum, like does attempt suicide, does not attempt suicide. Situations like this with a dichotomous outcome are really interesting, or can be really interesting from the perspective of what's sometimes called decision theory. So in these types of situations, we could imagine that our test, for instance, gives a particular person a rating of high risk for suicide, and then that person subsequently, unfortunately, does attempt suicide. We might call that a hit. Our test result matched correctly with the criterion. Of course, there could also be incorrect predictions. For instance, our test could identify a case that the criterion does not. So our test, for instance, puts the person at high risk, and then within some set period of time the person doesn't attempt suicide. That would be a false positive from the perspective of our test. We could also imagine a situation where the test misses a case that the criterion identifies. So our test says the person is at low risk, and within that reasonable or appropriate period, the person does attempt suicide, unfortunately. That would be a false negative. Our test missed that person. Decision theory, at least in this way of thinking about, largely boils down to evaluating these different outcomes, the numbers of hits, the numbers of false positives, the numbers of false negatives, assigning values to them, and then adjusting test sort of scoring criteria to maximize the total value of the test application. So if it's very valuable to have hits, and it's maybe very dangerous or not valuable to have false positives or false negatives, you sort of adjust the test up and down to get just the right mix where you have the best outcome when you use this test in this particular context. And I realize I'm being a little bit vague about this, but actually in my next lecture I'm going to talk a lot about decision making when we think about using screening instruments, tests which are designed to yield some sort of a dichotomous outcome, like the person is suicide risk or no suicide risk, or the person has depression versus they don't have depression. So suffice it to say, we'll talk about that more, and this is an area where we actually can get quite quantitative, and we can really talk numbers about validity, and that's in and of itself, I think, kind of interesting. But before we get there, let's just move on and finish this lecture, which I'm sure at this point you're probably happy with the thought of that being at over 40 minutes at this point. And we'll finish by talking a little bit about construct validity. Construct validity arose historically in an interesting context, and it was back in the 50s when the APA convened a task force to take a look at the ways in which we validate tests in psychology. And what was really an interesting and important important insight from that group, which incidentally involved Paul Meehl and Lee Cronbach, was that we are often in situations of test development where there is no perfect criterion. There is no gold standard test that we can compare our test that's in development to, or no perfect diagnostician or diagnostic technique which is very valid and very reliable. So that's a problem, right? Criterion validity only works if you have good criterions. What do you do if you don't have good criterions? Cronbach and Meehl, adapting some existing sort of philosophy of science, argued at the time that there's this other way of thinking about validity, and they called it construct validity. Now, you've encountered construct validity before in other classes, I'm sure, but just by way of a quick review, let's observe that a construct is an unobservable trait or quality. So it's an abstraction. It's something which is difficult to identify in a discrete and kind of concrete way. So if we think about depression, that's something that involves certain feelings, certain thoughts, certain tendencies or patterns in behavior that are real. We're not trying to claim that this stuff doesn't exist, but are not real in a very concrete way. What is real, or at least what is observable in a concrete way, are things like these behaviors, increased sleep, crying, self-expressed sad affect, and so on. Now, in psychology, again, where we have no one sufficient referent or one sufficient criterion for measuring a construct, we instead have to rely on a network of interlocking suppositions or ideas about that construct, something which Meehl and Cronbach called the nomological network. A more common or familiar way to describe what a nomological network is to just say that's our theoretical understanding of the construct. So we have a nomological network about depression. There are probably several or multiple nomological networks about depression, but let's say there's a basic theory as to what depression is, and that theory allows us to make a series of predictions about things that we could observe. So we can't observe depression, but using our theory we can make a set of predictions about stuff we can observe. Our theory of depression holds that depressed people are sad, and thus a rather simple prediction we could make is that if we identified a group of depressed people, and if we identify a group of non-depressed people, those depressed people on average are going to look sadder in terms of crying more, sad facial expression, and so on. A simple hypothesis that connects this unobservable abstract thing, the construct, to one observable concrete phenomenon, crying, and group differences in crying. You can imagine a whole network of these, a whole collection of them, which Meehl and Cronbach would call a nomological network. Nomological meaning just the thing that we use to name something, sort of a philosophy of science term. By the way, I can't help at this point noting the famous quote, which apparently was attributed to Kurt Lewin, although I couldn't find exactly where it was in his writings. But he is supposed to have said, "There's nothing so practical as a good theory." And what he probably meant by that is a good theory, a good nomological network for a construct, allows us to make and ultimately test, let's hope, a number of really good hypotheses, good predictions about that construct. Interestingly, just today I was clicking around on Twitter before sitting down to make this recording, and I saw a psychologist joking that there's nothing so impractical as a bad theory. So I guess it goes both ways. A good theory is valuable to us because it helps us feel like we understand a construct by giving us lots of good testable hypotheses or predictions. A bad theory does just the opposite. It confuses us or misleads us or makes us uncertain about what are or are not good hypotheses or predictions. Here's a nice attempt to pictographically represent a nomological network. A nomological network, incidentally, that involves more than one construct. I've been kind of limited in my discussion, but you could see here, that there might be some sort of meta representation, maybe of depression, which itself perhaps is some smaller subset of constructs, like depression is, loss of positive affect, depression is decreased behavioral activation, depression is changes in serotonergic functioning, and so on. Let's just say that your one construct could be kind of bifurcated or trifurcated into different other constructs. Each of these in some way is connected to observations, and what we could do to evaluate the kind of the robustness of this nomological network is to see to what extent these observations are related to each other in consistent ways. Are there predicted and testable ways of looking at the interrelationships among these observables? And to the extent that there are, and to the extent that our predictions hold and they're not falsified, then we start to feel sort of a la philosophy of science, Paul Meehl, Karl Popper, and so on, more confident in the validity of our construct, in the construct validity of our test. We might say rather simply that construct validity is the extent to which a test that claims to measure a construct really does, and in that sense construct validity is sometimes advanced as a unifying conceptualization of validity. It's like the one validity to rule them all, which sounds a bit Tolkien to me, but anyway, what it is, or how we think about construct validity, is as a way of looking at predictions. And those predictions can be criterion predictions, or content predictions, or other types of predictions that are in some sense smaller facets of validity. That's the way in which I think we can consider construct validity as almost this umbrella term which can capture up other types of validity evaluations or validity concerns. There are different ways of evaluating construct validity. There's no one ideal way, and ideally, I suppose, many different ways should be used. So it's all fundamentally about testing predictions. Predictions being hypotheses based on a good theory, a la the scientific method. Campbell and Fisk in 1959 wrote about the multi-trait, multi-method matrix, which in principle you could apply to situations like this. Here is an admirable attempt to pictographically represent what a multi-trait, multi-method matrix would look like. Here we're imagining we have three different constructs or traits which can be measured each in three different ways, and we would hope to see, if we're making multiple measurements, the highest correlations between measurements of the same trait or same construct with the same method. So you can see kind of in the upper left, somewhat weaker but still relatively strong correlations between measurements of the same trait with different methods, and the weakest correlations between measurements of the same trait, or of different traits or different constructs with different measures. So, people have criticized this approach somewhat, saying like, yeah, this in principle is doable, but practically speaking, it would be a real challenge to make and fill out this type of a grid. But again, you could imagine, I guess, doing it. It would depend a lot on what you're studying. If you're studying something like depression, you might have different measures for different constructs like depression, anxiety, and maybe some other feature of psychopathology, and you could look at the correlations between measurements of those constructs with themselves using these different measures. If we step away from that complexity for just a few minutes, we can note that there are some other kind of common ways of thinking about and evaluating construct validity. A big one of them is factor analysis, or looking at the factor structure of a test. So here, it's fundamentally about making and testing predictions. If we have a prediction that our construct has a certain set of underlying factors or components, then those should be visible in our test. If we believe that, let's say, mindfulness involves these different factors, one is attention to the moment, present focused attention. Another is non-judgmentalness. Maybe a third is compassionate feelings. Let's say that is our theory of what mindfulness is. Then a good test of mindfulness, a test which has good construct validity for mindfulness, should yield a factor solution that looks a bit like that. It should have a set of items which all group together that all seem to be about present focused attention. They should be another group of items which all kind of group together that seem to be about non-judgmentalness, and yet a third which seem to be about compassion. If we don't see that, if we see some other crazy factor solution, like there are 4 factors or there's only 1, then either our theory is wrong, which may certainly be the case, or the test is wrong. The test doesn't have good construct validity for that construct. Of course, it may be hard to know which is which, but suffice it to say that evaluating factor structure is often used to explore the construct validity of a test. Another thing you sometimes see, or another method you sometimes see for evaluating construct validity, involves looking at developmental change. So if we have a construct which we believe changes over time, we should be able to observe that change on our test. So let's imagine that we have some clinical instrument that's designed to measure response to treatment, changes in, let's say, cognitions during the course of CBT, or changes in the level of mindfulness in the context of over the course of mindfulness-based therapy. We should, if we have a theory that this construct changes, we should be able to observe those changes with our test. If we don't, if we see that, wow, people's negative cognitions don't change much over the course of CBT, then again, either our theory is wrong, maybe changes in cognitions are not as important as we thought, or maybe the test is wrong. And again, a bit like with factor structure, it may not be entirely obvious which is which, but again, suffice it to say that if we have constructs which are thought to change over time in a kind of a developmental way or a treatment responding way, then we should be able to predict and see those changes with our test. And doing so, assuming we get the prediction we want, should give us some information about the construct validity of the test. Of course, construct may not change, and we may not necessarily know when or why constructs change, but this is the problem. Yet another way of looking at construct validity would be testing group differences. Again, if we have a theory that different groups vary in terms of their level of this construct, we ought to be able to make those predictions and test them with our test. If we see the predictive results, then that tends to support the construct validity of the test. If we don't, then again, either the theory is wrong or the test is wrong. So again, it may just be the case that the construct doesn't in fact differ across men and women, or across people who use alcohol versus people who don't, or so on and so on. Hopefully you kind of get the point that evaluating construct validity is a lot like just science itself. It's the research process. You make predictions, you test them. If your results come out in ways that are not consistent with your predictions, it's often hard to know what to do. I mean, this is Imre Lakatos and other philosophers of science have spent a long time trying to figure out exactly what you do in these situations, but it may suggest to you that either your theory is wrong, your notion of the construct is wrong, or your methods are wrong. In the examples I gave earlier about developmental changes, my examples are really more about intervention-related changes, although in a sense those two ideas are very similar. To return to those really briefly, we might say that we have a theory that our construct changes over time. It could be level of depression, level of negative cognitions, level of mindfulness, whatever. If we can make those predictions and see responses to treatment that go in the predicted directions, then that tends to support the construct validity of our test. If we don't see those predictions, or those changes in the predicted direction, then maybe our theory is just wrong, or maybe our construct validity of our test isn't all that good. So hopefully, like I said before, hopefully you get the sense that construct validity is this important idea, but maybe even more so than other forms of validity, it's kind of difficult to arrive at some sort of very precise estimation of it. You could say that a particular test has good construct validity in a particular population because it shows the predicted factor structure, or it shows or reveals the predicted responses to treatment, or it shows the predicted group differences, and those statements would all tend to support the construct validity of your test, assuming that those statements all lined up with the predictions you'd make based on your theory of the construct. But it's not like you could say, well, the construct validity of our test is 0.7, and that's good, that's high, so good construct validity, yay us. Well, that's a long lecture, and so if you made it this far, thanks for your attention. I do appreciate it, as always. By way of a preview for next time, I'm going to focus on making decisions. I kind of briefly touched on that in this lecture. In the next lecture, I want to talk about it a lot more, because I think it's a fascinating area where testing is used, testing to inform clinical decisions, and it's an area in which we can do a fair bit of quantitative evaluation of testing and of the validity of testing. So it's important for us to talk about now. Again, thanks for your attention. Make yourself a cup of tea, make yourself a cup of coffee, and relax for a little bit. Let this information sink in. If you have questions, post them online or talk to me in person. I'll do my best to answer them for you. Okay, bye-bye.